Welcome to this video abstract. My name is Arya Hajmirzayan, first author of the abstract entitled Lateral patellar tilt and its association with 3 Tesla MRI-defined patellofemoral osteoarthritis, a longitudinal analysis of the osteoarthritis initiative cohort. This collaborative project was performed under supervision of Dr. Shatkur Demehri at the Johns Hopkins Hospital. I'm going to start with a brief introduction. Evidence showed that 35 to 65% of adult population have clinical or radiographic patellofemoral osteoarthritis, which is related to high level of pain and disability. Despite the importance and high prevalence of patellofemoral OA, insufficient evidence have focused on this medical condition, and risk factors of patellofemoral OA have not been completely investigated. In this slide, you can see the main causes and risk factors of patellofemoral OA, including modifiable and non-modifiable factors such as BMI and muscle strength. Malalignment and patellofemoral OA. Patellar malalignment can cause by various reasons, including trauma, overuse, and muscle dysfunction. Evidence showed that patellofemoral maltracking and malalignment, such as lateral shifted patella, may lead to a significant change in joint contact area and pressure distribution. These changes, especially during flexion-extension motions, can result in OA development and progression. Despite the mentioned evidence, there is a lack of studies to evaluate the potential role of lateral patellar tilt, or LPT, in patellofemoral OA development. And why this is important? Because LPT can be treated using a brace, physical therapy, or surgery, and can be considered as a modifiable risk factor. What are the main aims of our study? First, to evaluate the association between LPT measures on EMRI and presence of MRI-based patellofemoral OA using cross-sectional analysis. Second, to evaluate the association between LPT and worsening of MRI-based patellofemoral joint structural damage over 24 months using longitudinal analysis. Methods. We use data from the FNH project, which is a nested case control within the OAI cohort. FNH study was originally conducted in order to evaluate the role of MRI-based measures over 24 months as the potential biomarker for structural and symptomatic progression of osteoarthritis. This diagram summarizes the details of our study. As you can see, our exposure is LPT and our outcome is MRI-based patellofemoral OA. Baseline and 24 months MRI-based patellofemoral joint measures related to osteoarthritis were extracted. LPT was also measured on all 600 baseline MRIs. LPT was measured by 2 fellowship-trained MSK radiologists, which is defined as the angle between the posterior aspect of both femur condyles and the maximum width of the patella, as you can see in the figure. Outcomes. Our first main outcome is MRI cartilage score using Moog's method. Cartilage surface and full thickness were measured in all patellofemoral subregions, including lateral and the medial patella and trochlea. Regarding the scores, 0 stands for no cartilage defect, 1 for less than 10%, 2 for 10 to 75%, and 3 for more than 75% of subregion involving cartilage defects. Details are summarized in table and figure. Secondary outcomes are osteophytes and bone marrow lesions, or BMLs, scored using Moog's methods in all patellofemoral subregions. Osteophytes was graded based on the size. Grade 0 represents no osteophyte and grade 3 for large osteophyte. BML size was also graded based on the size of lesion in regard to the total volume of each subregion. Grade 0 stands for no BML, grade 1 less than 33%, and grade 3 more than 66%. BML number was also counted in each subregion. The statistical analysis. In the first arm of a study, or cross-sectional part, the association between LPT and baseline Moog's scores for patellofemoral osteoarthritis was assessed using fully adjusted regression analysis. In the second arm, or longitudinal part, the association between baseline LPT and worsening of each Moog's score was evaluated using the same adjusted regression models. Worsening of Moog's score was defined as any change in each of them over 24 months, as described earlier. All regression models were adjusted for confounding variables including age, sex, BMI, history of ACL injury, history of knee injury, frequency of kneeling, X-ray driven knee alignment, and tibiofemoral joint KL grade. Results. Table 1 shows the results of cross-sectional analysis. Let's start with the lateral regions, left columns. Significant associations were found between baseline LPT and presence of concurrent cartilage defects, BMOs, and osteophytes in all lateral patellofemoral regions with odds ratios of 1.05 to 1.1. In other words, each degree increase in LPT is associated with a 5 to 10% higher chance of having patellofemoral OA on lateral side. With regards to medial regions, the same association between LPT and OA-related structural damage were observed mainly for trochlear subregion. Table 2 summarizes the results of longitudinal analysis. In terms of lateral subregions, left columns, regression analysis showed a significant association between baseline LPT and 24-month worsening of BML in trochlear region with odds ratio of 1.05. Despite the trend, no other remarkable association was detected, which could be related to the short duration of follow-up. Conclusions. Higher measures of LPT is associated with the presence of OA-related features in a lateral patellofemoral joint. Each degree increase in LPT measure is associated with a 2 to 10% increase in odds of having patellofemoral OA. Finally, LPT might be considered as a modifiable risk factor for patellofemoral osteoarthritis. However, more research with longer duration of follow-up needs to perform.